So in 1847, walking into one of the premier medical hospitals in Europe to deliver a baby was actually statistically much more likely to kill you than, giving birth in a dirty alleyway.
Which is just a terrifying paradox.
It sounds totally absurd today, but that paradox is exactly why we're here right now. Because today we are unpacking a conceptual framework that, well, it finally solved that paradox and really changed how humanity fights disease.
It absolutely did.
Because, if an outbreak feels like this unstoppable avalanche like a force of nature that's just going to bury us all, the entire mission of our deep dive today is to give you a radically different perspective on that.
Right, because transmission is never actually inevitable.
Exactly.
Yeah.
We are exploring this core concept in nursing and epidemiology called the chain of infection.
Yeah, and it's this profoundly empowering heuristic once you realize how to apply it. It's essentially a 6-part mental framework that they teach to nurses on day 1 of infection control.
Day one stuff.
Literally day 1. It describes the exact mechanics of how a disease moves from one entity to another. And, early in the 20th century, public health taught this almost mechanically, like a fixed, discrete series of events.
Pathogen leaves body A, travels through the air, enters body B.
Exactly. But contemporary infection control science treats the chain more as a dynamic checklist for bedside clinicians who are dealing with really messy real-world outbreaks.
So I want to frame this using a bank heist.
Okay, I like that.
Think of an outbreak as a meticulously planned heist, right?
Yeah.
You have the criminal mastermind, the safe house where they hide out, the planned getaway route, the getaway car, the safecracker who bypasses the security, and then finally the vault itself.
Right.
To stop the heist, you don't actually need to arrest the entire crew. You just slash the tires on the getaway car.
Or you just lock down the safe house.
Exactly. The point is you only have to break one single link in the plan for the whole operation to just collapse. So our goal today is to map out exactly where those vulnerabilities are.
That is honestly the perfect way to visualize it. And the modern model we use to find those vulnerabilities is really a synthesis.
Meaning it wasn't just one person who came up with it.
Right. No. The CDC, which was actually founded back in 1946 to combat malaria in the American South, and APIC, the Association for Professionals in Infection Control.
Okay.
They popularized this formal teaching tool in the 1970s and 80s. Hospitals were building these dedicated infection control programs because, well, healthcare-associated infections were becoming a major crisis.
But this curriculum was built on older science, right?
Yeah, a solid century of older science, specifically the epidemiologic triad, which is agent, host, and environment, and, of course, germ theory.
So before we map out this modern heist, I was looking at the timeline in our sources, and something doesn't quite line up for me.
What do you mean?
Well, germ theory really takes off with Louis Pasteur's work in the 1860s, right? And Robert Koch formalizing his postulates in the 1880s.
Think about the 1880s.
Even John Snow traced that cholera outbreak to the water pump in 1854. All of that makes perfect sense. But the materials really highlight Ignaz Semmelweis in 1847.
Oh, Semmelweis. Yes.
If germ theory didn't even exist yet as an accepted scientific framework, how did he know what to do to stop an infection?
Well, he didn't know the biology, but he recognized the pattern, which really leads to one of the most incredible and tragic stories in all of medical history.
Tragic, huh?
So Semmelweis was a Hungarian physician working at Vienna General Hospital. He starts looking at the data on his maternity wards, and he notices this horrifying discrepancy.
The mortality rates.
Yeah. The hospital had 2 distinct maternity clinics. Women examined in the first clinic by doctors and medical students, who had often just come from performing autopsies, by the way, were dying of childbed fever at a rate of about 18%.
18%.
It's massive. But women in the second clinic, who were attended by midwives who did not perform autopsies, had almost 0 mortality.
So he sees this obvious correlation. But he has no concept of bacteria or viruses. He literally doesn't know what is transferring from the autopsy room to the delivery ward.
Exactly. He lacked the vocabulary of the infectious agent. He hypothesized that cadaverous particles were to blame.
Cadaverous particles.
Yeah. But he intuitively understood that something was being carried on the doctor's hands. So he mandated that physicians wash their hands in a chlorinated lime solution between the autopsy room and the delivery ward.
Why chlorinated limes specifically?
Simply because it was the only thing that removed the smell of decaying tissue from their hands.
Oh, wow.
And the results were immediate. Mortality on his ward plummeted from 18% down to roughly 1 to 2%.
That is incredible. Without even knowing the science of germs, he successfully intervened on what we now call the mode of transmission.
Exactly.
I mean, that should have made him a global hero instantly. He solved the paradox of the deadly hospital.
He really should have been celebrated, but instead he was just ridiculed by his peers. The medical establishment at the time believed diseases were caused by imbalances of the humors or, miasma,
Right.
bad air.
Right.
These gentlemen doctors were deeply offended by the implication that their own hands were somehow making their patients sick. It completely threatened their professional identity.
So ego got in the way.
Oh, absolutely. Semmelweis was dismissed from his post, suffered a severe nervous breakdown, and was actually committed to an asylum in 1865.
That's awful.
And in a really grim twist of fate, he died there a few weeks later from a wound infection.
Jeez. It's just a devastating example of what we now call the Semmelweis reflex.
Yes.
It's this innate human tendency, especially among highly trained professionals, to reflexively reject new evidence if it contradicts entrenched practice. Or, if it just threatens their ego.
Exactly. And it perfectly sets the stage for why we need structured, disciplined models in clinical settings.
Because we can't just rely on intuition. Human nature just gets in the way.
Right. We need a framework that bypasses all of that removes the ego and replaces it with a standardized clinical checklist. So let's walk through those 6 links, starting with the origins.
Okay, let's bring back our heist. Link number 1 is the criminal mastermind, the infectious agent.
Right, the pathogen itself. We are talking about bacteria, viruses, fungi, parasites, or prions.
The stuff Pasteur and Koch proved.
Yes, but for a clinician today, just knowing it's a virus isn't enough. An agent's ability to actually cause a crisis depends on its specific mechanics. You have to evaluate its infectivity versus its virulence.
Infectivity meaning how easily it spreads.
Yeah, how easily it establishes an infection in a new host. Virulence is how severe the resulting disease is.
Okay, I see. So you might have a mastermind who is incredibly stealthy but doesn't steal much, versus one who is clumsy but highly destructive.
Exactly.
Like a common cold virus. Has high infectivity but very low virulence. It spreads easily but rarely kills. But Ebola is kind of the opposite. It requires close contact with bodily fluids, so lower infectivity than a cold, but its virulence is catastrophic.
And that distinction dictates your entire response. As a hospital worker, your interventions at this first link involve aggressively targeting the mastermind. You use sterilization to destroy the agent on surgical instruments, and you implement antimicrobial stewardship programs.
To make sure we don't overprescribe antibiotics, right?
Right, which prevents the mastermind from mutating into a drug-resistant superbug.
Okay, so we've identified the attacker and we have weapons to fight them. But a pathogen can't just float in a void indefinitely. It needs a staging ground to multiply before it makes its move.
The safe house.
The safe house. This brings us to the second link, the reservoir.
The reservoir is where the agent normally lives, grows, and multiplies, and this is actually where a lot of people outside of epidemiology get tripped up.
Because it's very easy to assume the reservoir is just, a sick patient coughing in a hospital bed.
Right, and that is the most visible reservoir, but certainly not the only one. Reservoirs can be animals. They can be environmental sources like soil, standing water, or even like the damp environment of a mop head.
A mop head.
Yeah. And when we look at human reservoirs, they can be completely asymptomatic.
Like Typhoid Mary. The sources highlight her, and she is just the ultimate hidden safe house.
She is the textbook illustration of an asymptomatic reservoir. Mary Mallon was a cook working in New York City in the early 1900s carrying Salmonella typhi, but she never appeared sick a day in her life.
Not even a fever.
Nothing. She was colonized with the bacteria.
Meaning what exactly?
Colonization means the pathogen is living and multiplying inside a host without triggering a systemic inflammatory response. No active disease. She felt perfectly fine, yet she was actively shedding the bacteria into the food she prepared.
And causing dozens of typhoid cases across all these wealthy households. You wouldn't look twice at her, but she was crucial to the heist. Which really highlights why interventions at the reservoir link have to go beyond just treating visibly sick patients.
You have to identify carriers, isolate them, and decontaminate the environment.
Because if you only look for people who are coughing, the stealth safe houses will just keep launching new attacks.
Exactly. And once the agent has multiplied in the safe house, it needs a way out to commit the crime. That brings us to the third link, the portal of exit.
The getaway route.
Yep, exactly how the agent leaves the reservoir. If it's a respiratory virus, the getaway route is the respiratory tract when you sneeze, cough, or even just talk.
Or for gastrointestinal pathogens, it's through stool.
Right. It could be blood, open skin lesions, mucous membranes.
And breaking this link seems highly mechanical. It's just source control.
Very mechanical. Putting a mask on an infected patient physically traps those respiratory droplets before they escape the room, or sealing a seeping wound so the bacteria can't hitch a ride out into the environment.
So we've tracked the pathogen from its existence to its home, to its escape route. It has breached the perimeter of the safe house. Now we hit the fourth link, the mode of transmission.
The getaway car.
The getaway car. This describes how the agent travels from that exit point across the intervening space to a new victim. And this is widely regarded as the single most consequential and most controllable link in the entire chain.
Absolutely.
So how does the pathogen actually cross the distance?
It relies on different vehicles depending on its biology. It can travel through direct physical contact or indirect contact via a fomite.
A fomite being like any inanimate object that can carry an infection. A bed rail, a doorknob.
Or a doctor's unwashed stethoscope.
That serves as an indirect taxi for the bacteria.
A very common getaway car, unfortunately. Other modes include droplet spread, airborne spread, a common vehicle like contaminated food, or a vector like a mosquito.
And this link is where hand hygiene lives.
Yeah.
But this is also where we see some incredible real-world detective work when a new getaway car is discovered, like the 1976 American Legion Convention in Philadelphia.
The outbreak that literally gave Legionnaire's disease its name.
Right, because 182 people fell inexplicably ill and 29 died from this severe, unidentified pneumonia.
And the investigators had to figure out the chain of infection completely from scratch. They eventually traced the bacteria Legionella to the hotel's cooling tower.
Wait, the air conditioning system.
Exactly. The AC water system was the reservoir, but the real breakthrough was understanding the mode of transmission.
Because how does water in a cooling tower get into someone's lungs?
Well, the towers were aerosolizing the water. They were turning the contaminated water into this fine mist of microscopic droplets. When the attendees breathed in that mist, the droplets were small enough to bypass the protective cilia in the upper respiratory tract and travel deep into the lungs.
Oh, wow. And that discovery completely reshaped how facilities operate, right?
Yeah.
They essentially slashed the tires on the getaway car by changing how we clean and maintain commercial air conditioners.
Turning plumbing and HVAC maintenance into a literal infection control responsibility. It proved that managing the environment is just as critical as managing the patient.
So once the pathogen survives the journey in its getaway car, it arrives at the target.
Yeah.
The fifth link, the portal of entry. We need the safecracker to pick the lock on the human body. How does it get inside?
It exploits vulnerabilities. It enters through broken skin, mucous membranes, the respiratory tract, or directly into the bloodstream.
And in a modern hospital setting, parenteral entry, meaning entry through a needle or a catheter, is a massive concern.
Huge, because we are intentionally puncturing the body's natural armor to deliver care.
Which raises a really fascinating point about how hospital culture manages those artificial portals of entry. The materials highlight the Keystone ICU project led by Dr. Peter Pronovost in the mid-2000s.
Yes, such a landmark project.
He went into intensive care units across Michigan to target central line-associated bloodstream infections, or CLAB-SIs. A central line is essentially a catheter highway placed into a large vein going straight toward the heart.
It is a massive vulnerability.
And what he did to protect that portal was so elegant. He didn't invent a new multi-million-dollar robotic tool. He just created a 5-step checklist.
Just a simple piece of paper, wash your hands, use full barrier precautions like sterile drapes.
Clean the patient's skin with chlorhexidine.
Right. Avoid inserting the line in the groin area if possible, and remove any unnecessary lines.
And the results were staggering. Published in the New England Journal of Medicine in 2006, the median rate of these deadly bloodstream infections across participating ICUs fell close to zero.
Close to zero, within about a year and a half.
But the brilliance of Keystone wasn't just the medical steps. It was how it bypassed hospital hierarchy. The checklist gave nurses the institutional authority to halt a procedure if a senior doctor skipped a step.
It broke the human error component by making flawless aseptic technique mandatory, regardless of whose ego was in the room.
It was the modern cure for the Semmelweis reflex.
Beautifully put. It's a massive demonstration of breaking the portal of entry link through disciplined collective action. Which brings us to the final link in the chain, The pathogen has picked the lock. Now it stands in front of the vault. Link number 6, the susceptible host.
This is the individual actually receiving the pathogen. An infection only takes root if the host's immune defenses fail to stop the mastermind. But the crucial takeaway here is that susceptibility is not a fixed trait.
No, it is highly dynamic. It fluctuates. It rises with extremes of age. So the very old or very young are more vulnerable. It rises with chronic diseases, malnutrition, or immunosuppression from chemotherapy.
And like we just talked about, it rises significantly if you have medical devices bypassing your skin's natural barriers.
Exactly. So the interventions at this final link are all about actively reinforcing the vault. We modify that susceptibility through nutritional support, getting patients moving early after surgery.
To clear their lungs, right?
Right. And critically, minimizing the duration a patient spends with an invasive device. Risk accumulates with time. A catheter left in for 5 days is fundamentally more dangerous than one left in for 2.
The faster you remove it, the faster you shrink that portal of entry.
And reduce overall host susceptibility. And of course, the ultimate reinforcement for the vault is vaccination, which pre-trains the immune system to recognize and destroy the agent immediately.
So this all sounds incredibly elegant on paper. We map the heist, find the vulnerability, and intervene. But the real world is chaotic. Where does this model fall apart, or where do we just get it wrong?
Well, we don't have to look far for a masterclass in how misclassifying a single link can cause a global failure. The most consequential recent failure involving this exact framework played out during the early months of the COVID-19 pandemic.
Specifically at the mode of transmission link.
Yes. The early guidance from the WHO and the CDC classified the transmission of SARS-CoV-2 primarily as droplet spread.
And in infection control, words have very precise physical meanings.
Very precise. Droplets are relatively large, heavy respiratory particles. Because of their mass, gravity pulls them down quickly. They usually fall to the ground within roughly 3 to 6 feet of the person who coughed or sneezed.
So if a pathogen is spread by droplets, standard surgical masks and a few feet of physical distancing are generally enough to break the chain.
Right. But then, in July 2020, 239 scientists across 32 countries published this massive open letter pushing back on the establishment. They argued the physics simply didn't match the epidemiological data. The evidence was pointing to significant airborne transmission.
Which fundamentally changes the getaway car.
Completely. Airborne transmission involves aerosols. These are much smaller, lighter particles. They don't fall to the ground. They stay buoyant and suspended in the air on ambient currents, sometimes for hours.
They can travel far beyond 6 feet.
Oh, easily drifting across a room, especially indoors with poor ventilation. To break an airborne mode of transmission, a loose-fitting surgical mask is insufficient. You need an N95 respirator that creates a tight seal.
And you need specialized negative pressure hospital rooms that actively suck air out through HEPA filters.
Exactly. The public health agencies did eventually revise their guidance to acknowledge aerosol spread, but that initial misclassification cascaded into a disaster.
Because we misidentified the getaway car, we issued the wrong tires to slash. We prioritized scrubbing surfaces and using plexiglass barriers, which actually plexiglass blocks airflow and can trap aerosols in a room while kind of neglecting high-quality respirators and ventilation.
It really echoes the tragedy of Semmelweis. When the institutional framework refuses to quickly adapt to new evidence regarding transmission, patients suffer. But it's not just systemic failures. Everyday misconceptions can trip up even experienced clinicians.
Oh, I want to bust one of the biggest myths you see every day. Hand sanitizer.
Oh, yes.
Pumping that alcohol foam onto your hands feels like you are equipping this magic, impenetrable shield.
Alcohol-based sanitizer is fantastic for many pathogens, but it absolutely does not kill everything. A perfect example is Clostridioides difficile, or C. diff.
That's the bacteria that causes severe colitis, right?
Yes, highly contagious. C. diff survives in the environment by forming spores. These spores have a really tough protective outer coating. They are entirely resistant to alcohol.
Wait, entirely?
Entirely. You can bathe your hands in sanitizer, and those spores will just sit there on your skin, waiting to be transferred to the next portal of entry.
So if the alcohol doesn't pierce their armor, how do you break the transmission link?
You have to rely on mechanical friction. Good old-fashioned soap and water.
The soap kills them.
Well, the soap doesn't necessarily kill the spore. Instead, the physical act of scrubbing creates a shearing force that dislodges the spores from the microscopic ridges of your skin, and the water just washes them down the drain.
Oh, I see.
That's why the absolute standard for a C. diff room is wash in, wash out at the sink. If you rely on sanitizer, you are actively facilitating the heist.
Wow. Another reality check for this model is that we teach it as a single sequential narrative, right? Mastermind to safe house to getaway car to vault. But in a real hospital ward, say you have a highly infectious norovirus outbreak sweeping through, it's not a single line.
Not at all. It is a massive, chaotic network of overlapping chains. At any given moment, a single patient on that ward can be a portal of exit for one pathogen, a reservoir for a second, and a susceptible host receiving a third.
That sounds exhausting to manage.
It is. The six-link model is an incredible heuristic for breaking down the mechanics of a single transmission event, but it requires a really disciplined team to manage dozens of these overlapping chains simultaneously.
And if we pull back even further, some epidemiologists argue the model is structurally incomplete for the modern world anyway.
Specifically, social and structural epidemiologists. Their critique is that the chain is intensely biologically focused and individually oriented.
Right. It does a masterful job of documenting the mechanics, how a virus gets from a sneeze into a lung. But it has very little to say about the socioeconomic forces that determine who becomes a susceptible host in the first place.
Exactly. It doesn't account for poverty, severe crowding, or a lack of access to clean water and preventative health care. If you are investigating non-communicable diseases or conditions with complex causes like asthma clustering in specific urban populations near highways, the chain of infection just isn't very helpful.
We use different frameworks for that.
Yes, epidemiologists utilize frameworks like McMahon's web of causation, which maps out dozens of interacting, nonlinear socioeconomic and environmental factors. But for acute, communicable infectious diseases, the six-link chain remains the absolute gold standard for bedside intervention.
So let's bring all of this together. We've traced the evolution of infection control from 19th century Vienna to the physics of modern aerosols. If you want to carry the core insights of this framework with you, here are what you need to remember. First, you only need to break one link to stop an outbreak. You don't have to foil the entire plan.
Second, hand hygiene remains our most powerful weapon because it directly sabotages the getaway car for countless pathogens.
Third, we have to look past the visibly sick, because stealth safe houses, asymptomatic reservoirs are everywhere. Fourth, your susceptibility is a dial we can turn up or down. It is not fixed.
And finally, understanding the physics of how a disease travels dictates our entire survival strategy.
The reason this deep dive matters is that the stakes are immediate and incredibly high. CDC surveillance data shows that on any given day, a meaningful share of all hospitalized patients has at least one healthcare-associated infection.
These aren't abstract concepts. These infections lead to extended hospital stays, massive additional treatments, and entirely preventable deaths.
This framework is a fast, actionable mental checklist that empowers frontline staff to save lives in real time. And on a macro level, it is the exact foundation for public health policy.
When you understand the chain, you finally understand the why behind the rules. You see how a mask mandate targets the exit and entry portals, or how ventilation targets transmission.
I want to leave you with one final thought to mull over, building on the heist metaphor. We talked about how you can reinforce the vault, the susceptible host, by getting vaccinated. But consider what happens when millions of people do that simultaneously.
We enter the realm of herd immunity.
Exactly, herd immunity and the basic reproduction number, or R0. By shrinking the susceptible host link across a massive population, you aren't just putting a shield around one person. You are fundamentally altering the environment itself.
It is the ultimate systemic intervention.
You create a world where the pathogen executes its plan, leaves the safe house, reaches out to grab the next link in the chain, and there's just, nothing there. You literally starve the outbreak because there are no getaway cars left to steal and no vaults left to crack.
Leaving the mastermind with nowhere to go.
And suddenly that unstoppable avalanche, it never even starts.